Welcome to the webinar, Psychology of Child Occupant Protection. This webinar is sponsored by the Maryland Institute for Emergency Medical Services Systems and brought to you through funding by the Maryland Highway Safety Office. I am Suzanne Ogaitis-Jones, your moderator. I coordinate the Child Passenger Safety and Occupant Protection Healthcare Program at MIMS. Now, I'd briefly like to introduce our keynote speaker and our panelists. And since we don't have the active visual of our faces, I've included photos so we can maybe recognize each other in the future. Our keynote speaker is Emma Sartin. She's a postdoctoral fellow at the Center for Injury Research and Prevention at the Children's Hospital of Philadelphia. Our panelists are Dr. Rebecca Rabin, a pediatrician who works at LifeBridge Health's Green Spring Pediatric Associates, Beatrice Brathwaite, Senior Injury Prevention Coordinator in the Division of Pediatrics of the Trauma and Burn Department at Johns Hopkins Children's Center, and Nancy Boyd, who's been an injury prevention and community health nurse for the past 30 years, working in Frederick County's health department, hospital, and several community healthcare centers, including the Asian American Center of Frederick. She's also been a leader in Safe Kids Frederick County. So now we would like to turn this over to Dr. Sartin.
All right. Hi, everyone. I am extremely excited to be here today talking to you guys about the work I've been doing from about the last year now. I'm going to wait just a second to give my PowerPoint a chance to load into full screen before I really get going here. All right. So before I get started, I do want to say I don't have any conflicts of interest about this research. And the research that I'm reporting today was funded by the Dwight Eisenhower Transportation Fellowship Program and the University of Alabama at Birmingham Department of Psychology. I'd also like to acknowledge a few people from a very long list who have contributed to the research that I am presenting today. So a lot of this work was completed as part of my dissertation from my graduate program. So my dissertation committee really helped and contributed a lot of both physical resources as well as intellectual contributions. I also had a fantastic research team that helped me with data collection and management. I was able to complete an amazing internship with Safe Kids Alabama, specifically with Marie Crew and her team, who also helped me really shape this research to make sure that it had practical real-world applications. And then I'd also like to thank my current postdoc mentor, who is really helping me continue this line of research and develop it at CHOP. For the overview of my talk, I'm going to start by giving you a little bit more information about me and how I've kind of ended up as a child occupant protection researcher. And then I'm going to give you very high-level details and implications from 3 different studies that I've completed. For the purpose of this talk, for both the time and the overall diversity of the people who might be listening to this talk, I am sticking to those high-level details. If these studies have been published, I included the citation on certain slides so that you can find them and find all of their details. But I'm also more than happy to discuss them more individually if anyone wants to reach out. After I go over each of the studies, I'll give you kind of the very utmost high points that I think are the most important pieces before we move into the discussion with our panelists today. So a little bit about me. I completed a dual degree PhD and MPH program at the University of Alabama at Birmingham. My PhD is in developmental psychology, and my dissertation was examining the factors and influences at the child, context, and caregiver level that influence a child's injury traffic risk. While I was completing my MPH for health behavior, I did complete an internship with Safe Kids, like I described earlier. I've been a CPST since 2018. I actually was a CPST to, I did the training just for my dissertation work, but I have stayed involved as a CPST and recently renewed my certification. Since I graduated last August, I have been a postdoctoral research fellow at the Center for Injury Research and Prevention at the Children's Hospital of Philadelphia. So I'm going to get right into the first study, which is a systematic review and meta-analysis of child restraint system interventions. Again, that citation is in the pink writing below. This study was published in JAMA Network Open back in October of last year. For a little bit of background, a meta-analysis is a statistical procedure for combining data from multiple studies. They're often used to determine if interventions for a given problem or interest work, as well as to compare different interventions to determine what characteristics work best. When I was first developing my dissertation and doing a pretty in-depth literature review, I realized that there's never been a meta-analysis for interventions trying to improve child restraint system use. So very simply, the objective of this study was to use meta-analysis to determine if interventions to improve child restraint systems work, and if they do, identify traits of those with the most success. So figure out what different characteristics of interventions are those that are most successful. That way we can inform future interventions so that we're not continuously recreating the wheel. For our methods, we followed the Cochrane and PRISMA guidelines, which have been established to ensure high rigor with meta-analyses. We searched 2 different databases, PubMed and PsycInfo, using 3 different search terms. So there were 6 searches completed total. Our studies were limited, so to be included in our meta-analysis, the interventions had to be published in the most recent 15 years. So between 2004 and 2019, there was a lot of very great work done before that, but we're trying to really find the most relevant data. So we wanted to keep it as close as we could to current dates. And lastly, for the criteria for each study that had to be true for each study included in the meta-analysis based on those Cochrane and PRISMA guidelines were that they had to target caregivers. So we excluded interventions that were for nurses or teachers in childcare centers and only used those that had parents or caregivers as the participant. They had to focus on increasing child restraint system use and not knowledge in child restraint systems or confidence in use. It had to report actual rates of child restraint system use. They also had to report that rate before and after the intervention and had to have a control or comparison group. And that was so we could calculate the unadjusted odds ratios, which is the statistic that is plugged into the meta-analysis. For our search, we first identified about 1,200 articles. We removed duplicates in any interventions or studies that were completely not relevant to the purpose of this paper. We identified 51 full-text articles that we very closely looked at to examine those criteria that I described earlier, which ended up reducing the number of studies that were included in this analysis to 10. So we excluded 41 more articles after that full text review. And I will say that the majority of those that were excluded at that level did not have a control group or reported their data in a way that we could not calculate those odds ratios, which means we couldn't compare them to the rest of the studies. For those 10 studies, they are listed there on the left with the date that they were published. They provide us about 8,238 participants total to use in the meta-analysis. And some important characteristics of each of the interventions. We had 3 studies that were implemented in community-based settings, 3 were in hospitals, 2 were in childcare centers, and 2 were implemented virtually. 1 was in a mobile phone app and 1 was in a computer kiosk setup. And their method, when I refer to their method, I'm talking about how they measure changes in child restraint system use. So the gold standard for studies would be to use an observational method, meaning a trained research staff member or a child passenger safety technician in many situations examined the participants' vehicles to see if they were actually using a child restraint system. The other method that could be used was using self-report, meaning that the research team contacted the parents and asked them, are you using a child restraint system? So 100% of our community-based studies and childcare center-based studies used observation methods, while all of the virtual studies and most of the hospital studies used a self-report method. When we used or plugged all of our numbers into the meta-analysis, we did find that caregiver-targeted interventions work. And this table has a lot going on in it, so I'm just going to focus mostly on explaining this graph. So in this graph, each of the squares that you see here represent a different study that was included in the meta-analysis. The size of the square represents how many participants the study had in it, which also represents how much weight the study had in the statistical analysis. If studies fell, when we plotted them on this graph, if they fall directly on this dotted line, it would indicate that they had no effect whatsoever. So they did not increase child restraint system use, but they also did not decrease child restraint system use. If they fall to the right side of this dotted line, it would suggest that they decreased child restraint system use, which would be the opposite effect of what we would hope for a intervention hoping to improve child restraint system use. And lastly, if they fell on the left side of the dotted line, it does indicate that they were successful and increased the number of children riding in child restraint systems. You can see that the majority of the studies do fall to the left of that dotted line, which is great. This blue-gray diamond down here at the bottom of the graph, the middle point of that diamond indicates the average effect of all of the interventions, which is again on the left side of the graph. So it suggests that caregiver-targeted interventions do improve the number of children riding in child restraint systems. When we examined this a little bit closer, we did find that hospital-based interventions and those that relied on participant self-report of CRS use. Also, when I say CRS, I do mean child restraint systems, just to clarify that. But they did find that those two characteristics were associated with the interventions that were most effective. However, we decided that this is a misleading finding, primarily because most of our hospital studies use self-report methods, which drastically overestimate positive behaviors like child restraint system use. So in other words, we think that people lie quite often when you ask them to self-report a behavior, especially after they've received an intervention telling them that they should be doing a certain thing. So in this case, parents who participated in a car seat intervention and then were called or emailed after a certain amount of time and asked, hey, are you using a child restraint system, might feel pressure because they know what the right answer is. And their restraint use was not verified by someone on the research team. So it's likely that those studies are quote, more effective because they have a little bit of a bias included in them. In this study, we also found that the majority of the interventions included in our analysis did not have rigorous evaluation methods or implementation methods. The best example I can give of this is that several studies allowed participants to self-select whether they were in the control group or the intervention group. And that creates something called self-selection bias, and it makes your control or comparison group not valid because they were probably less likely to change their behavior to begin with, while the people who want to participate in an intervention about child restraint systems are more likely to change behaviors. We also found that there were very few interventions that existed or were effective in minority families. Those who were effective in minority families tended to be tailored to a specific minority group. So for example, they were developed for Hispanic populations and implemented in the Hispanic community. So I'm going to move on to the second study now. Again, that citation is down there in pink. This study was very recently published in the Journal of Safety Research, just at the beginning of June, and focuses on behavioral considerations for transitioning children between harnessed and booster seats. So as many of us are aware, in 2018, the American Academy of Pediatrics updated their best practice guidelines. The new guidelines do not include age-based recommendations and focus on fitting the child to the restraint based on the manufacturer's guidelines. So really stress that the child should be within the seat requirements and they should remain in that seat until they no longer can. They also state that delaying seat transitions is best. And the main reason that this major change in guidelines took place was because they wanted children to be rear-facing longer than the age of 2, if possible. So they were finding a lot of people were just following those age-based guidelines when we really want them to delay those seat transitions as long as possible. However, we were concerned about the lack of information provided for caregivers around other seat transitions, such as the forward-facing harness seat transition into a booster seat. Specifically, we were concerned that these new guidelines may result in people prematurely transitioning their child from the harness seat to the booster seat. So the new guidelines do state that children, that there are forward-facing harness seats that can accommodate children up to 65 pounds. However, many high-back booster seats have minimum weight requirements of 30 pounds. According to CDC statistics, the majority of children in the United States reach about 30 pounds before they are 3 years old. And that data was actually collected in the early 2000s. So this is just me speculating, but based on obesity trends, I think that it might be a little bit sooner than that now. However, I don't have the data to support that. On top of that, so not just because children are a good fit for booster seats, but booster seats may be appealing to parents because they're much cheaper than harness seats often, and they're less bulky. So they fit in cars better, they're easier to move around, and the child can buckle themselves in and out pretty easy. So for families who have multiple children, that booster seat may be more appealing when you have other seats that are clunkier and harder to position in the car with another harness seat. So this is dangerous because previous research has shown that booster seats are less protective than the harness seats, even for older children who are topping out at the weight of the booster seats. They just don't offer as much protection as some of the harness seats do. And they allow the child to move around more. So they have more flexibility, they can move the restraint or the seatbelt around, which could cause a lot of problems. So the objective of this study was to extend previous research observing child behaviors during vehicle trips to determine differences in the amount of time children spend in unsafe positions based on the seat they're seated in, so a forward-facing harness or a booster seat. To achieve this objective, we recruited 50 mothers and their child who was 4 to 8 years old. They completed a real-world observation as well as a simulated observation. For the real-world observation, a child passenger safety technician inspected the mother's vehicle to determine if the child was seated in a CRS. If they were, the CPST then evaluated if the seat was installed correctly and if the child was using the seat accurately. So were they harnessed incorrectly? Was the belt where it was supposed to be? And also, was it installed into the vehicle appropriately? After that real-world installation, the mother and child were brought into the room where we house our advanced driving simulator, which is pictured here. I'll give you a little bit more information about that in just a second. But when they were brought into this room, we gave the mother either a forward-facing harness seat or a high-back booster seat that both were available in the market and are very widely used brand. So we did not try to trick them in any way, but they were given a seat based on what we saw in their real-world observation. So if the child arrived to the study appointment seated in a harness seat, the mother was given a harness seat to then put into the simulator. And same thing with the booster seat. If the child showed up to the study visit without a child restraint system, we used their height and weight to make sure that they could sit in a booster seat. If so, they were given a booster seat. If they were still a little bit too small for the booster seat, especially height-wise, we put them in a harness seat again. But we did that because we wanted the children to be as close to what they were normally, or what they were used to sitting in as possible. So we gave them one of those two seats. The mother installed the child restraint system into the back seat of the simulator and put the child in it, and then they took a short drive together. The driving simulator is a high-fidelity, fully immersive instrument designed by Real-Time Technologies Incorporated and is outfitted with a 2016 Honda Pilot. So everything about the simulator on the inside looks like a 2016 Honda Pilot. It has a full dashboard navigation system, all of the bells and whistles that you would see in the 2016. It has fully functional latch in the back seat. All of the seat belts are fully functional. It also sits on a motion-based system, which allows the vehicle to be at a normal ride height for ingress and egress, while providing the driver with pitch cues for accelerating and braking. So it looks like a real car, functions like a real car, and also has a motion-based system that gives cues to the driver to make it feel like you're traveling. You can see the screens wrap around the simulator, so it does look very realistic. The total drive that the parent and child took together was about 10 to 12 minutes based on how fast the mother drove through our simulation. And we also had a GoPro mounted right under the rear view mirror that faced in towards the mother and the child in the back seat. We took the videos that were recorded from that GoPro to code children's behaviors during the vehicle trip. There was a warm-up period that we did not include in our coding that allowed the child and the parent to get used to sitting in the vehicle and the animations and overall experience of being in the simulator. We specifically focused on whether or not the child was seated in a safe a safe position. And an unsafe position was defined as one that would reduce the effectiveness of the child restraint system in the event of a crash, or in a position that was not approved by the manufacturer, so not safety tested in this manner. So this is an example from one child participant who gave us several examples of unsafe positions to use. So in the first panel, the child is seated correctly in the seat. I also apologize for how dark these pictures look. In the actual videos, it's very clear where the high back booster is in comparison to the vehicle seat, as well as how the child is seated. But when I grabbed the screenshots and pulled them out, it kind of messed up the quality of the overall image. So in this first panel, you can see the child is seated correctly. Their back is up against the high back booster, and the high back booster is flat against the vehicle seat. The seatbelt is also across the child's chest as it's intended to be. In the second panel, the child is leaning all the way forward so that their back is not against the high back booster. Their head is completely forward. In this image, the child is looking out the window and trying to get a better view. The child is also pushing themselves up out of the seat so that their rear end is no longer seated on the seat. In the third panel, you can see the child is leaning sideways. They have actually moved the seatbelt around their stomach and is leaning as far to the left as possible, which has pushed the high back booster actually to be not flatly sitting on the vehicle seat, and half of the base is off of the base of the vehicle. And in the last image, you can see the child is looking out the rear window. The seatbelt is still around the child's waist, and the child is almost entirely out of the seat. So all of those would be unsafe positions. We took the amount of time that the child spent in all of these unsafe positions, added that time together, and divided it by the total trip time to get a variable that we call the percent of time in an unsafe position. Our overall participants, we had 14 children who were in harness seats and 36 children who were in booster seats. We had a slight majority of Black or African American mothers and a slight majority of female children. However, they were not statistically different than, it was just a few more children, or a few more in either category. When we coded the videos and analyzed them, we found that none of the children in harness seats spent any time inappropriately restrained. So if they were in a harness seat, there were no child-induced errors, and they were correctly seated in the seat the entire drive. However, this was not the case when we looked at booster seats. So I'm going this graph very briefly. On the horizontal axis down here, the child's ages in years, so 4 to 8. And then the number in parentheses indicates how many children that age were in each age category. On the vertical axis is the percent of the drive inappropriately restrained. So you can see our 8 4-year-olds who were in the study spent about 75% of their total drive in an unsafe position, compared to all of the other age categories, which were below 30% of the drive in an unsafe position. Well, that is a very stark difference that I think is very important to consider. I also want to highlight these dots that are outside of the main blocks of averages. These dots are representative of outliers, meaning they are children who did not look like their age. So, for example, you see this 4-year-old looked closer to the older age groups down at the bottom than the actual 4-year-olds. However, there's also a 7-year-old who looks more like a 4-year-old than the rest of the 7 and 8-year-olds. So there are important individual child level differences to consider, as well as maybe this age consideration. In conclusion, for this study, on average, 4-year-olds spent the majority of the drive inappropriately restrained, while all other age groups spent the majority of the drive properly restrained. However, there were also important individual differences across each of the age categories. For implications, these findings suggest that not all children who are physically compatible with booster seats are behaviorally mature enough to use them. Moving forward, we might be able to improve this transition period by incorporating some of these considerations into the design of booster seats themselves, so making them more comfortable for smaller children, or providing more protection or more reinforcement so the child stays still. However, we're not really there yet, and that's not my job. So my recommendation is that as primary sources of information that caregivers seek out, CPSTs and providers really need to remember behavior as an important factor when counseling families about when to transition into a booster seat. I do fully acknowledge this is a complex issue, as most people who have embarked on starting to help families with child restraint system use know, primarily because every child is different and has different needs. So I think that this will especially get more and more complex as children continue to have higher rates of obesity and might be aging out of their harness systems a little bit sooner. And again, there's also the differences in price points, I think, which is really important to consider, where while a harness seat who accommodates children up to 65 pounds exists, they're much more expensive than the booster seats, which could result in disparities happening. Which brings me to the next study, focusing on disparities in child occupant protection. I do not have, this work has not been published in any peer-reviewed journal. We've presented it at a few conferences recently, but we're using it primarily as preliminary data and are building this out more at my time to CHOP. For this section, I am focusing mostly on disparities in Black or African American groups. However, I do want to acknowledge, I know that there are disparities that exist for other minority groups as well, including Hispanic and Native populations. So the good news is, since 1975, child occupant fatalities have decreased by 54%. So we're doing a really good job in getting that number down over the last several decades. I also want to say most of these statistics I pulled from the CDC Whiskers database. While we've decreased the overall amount of fatalities by 54%, still about 3 children in the United States die in a crash every day, and about 100,000 more are treated for injuries in emergency departments, which cost about $530 million annually. Unlike other unintentional injury causes like poisonings and drownings, we're seeing disparities in child occupant protection growing. And what I mean by this is the fatality rate for white children continuously ticks downward every year, while the fatality rate for minority children does not. It's kind of plateaued, so that disparity, the difference between the fatality rates is getting bigger instead of getting smaller. We can see this in Black children die in crashes at twice the rate of white children every year, despite being a smaller portion of the population. And Black and other minority children are substantially less likely to be restrained in child restraint systems at all ages. Particularly troubling statistic I came across not too long ago from a study published in 2018 was that for children aged 1 to 3, about 85% of Black children were restrained in some type of child restraint system, compared to 97% or more of all other racial and ethnic groups. So while 85% is still the majority of children, that's a big difference between that age group and the different racial and ethnic categories. While these disparities exist, so we have them documented in several studies and several national databases, we really don't understand why they exist. And because we don't have this understanding, as I mentioned earlier in the first study, there aren't very many interventions tailored for minorities that are super effective. There's also an issue with child passenger safety legislation, which has found mixed effects in minority groups. So sometimes people report increases in rates of child restraint system use, but other times they've reported harmful effects of child passenger safety legislation, and that these populations are getting penalized because they don't have resources to follow the laws or the information available to them. But also we're seeing that child passenger safety laws can actually prematurely place children in the wrong seats or put them in booster seats before they're ready to be specifically. So the objective of this study was to conduct preliminary analyses to determine factors that contribute to disparities in child occupant protection. For this study, we had 43 mothers complete the real-world inspection I described earlier, where a CPST inspected their vehicle. And we also asked them if they had received any kind of anticipatory guidance about child passenger safety at their last well-child visit. So from their pediatrician's office at the last time they went in for their annual visit, did they get any kind of information about child passenger safety? So it could have been with the discussion of the pediatrician, or it could be pamphlets. We didn't really care what mechanism the information was delivered. We were interested, did you receive any kind of guidance or information? For these graphs down here, the darker blue bars indicate white mothers and the lighter blue bars indicate minority mothers, which were primarily Black or African American. So the study did take place in Birmingham, Alabama, which is why it leans in those two categories. So the dark blue in this first figure, you can see it is child restraint system use split by the race ethnicity groups. All but one of our white mothers was using a child restraint system in their vehicle during the real world inspection. However, the minority mothers, it was almost 50-50 split of who was using one and who was not. This idea kind of flips when you look at the PCP guidance. When I say PCP, it's primary care provider. You can see about half of the white mothers reported that they had received guidance and half reported that they had not received guidance. However, 87% of the minority mothers, or all but 3, reported that they did not receive any kind of guidance about child passenger safety. And this might be, a lot of people may be thinking at this point, well, does that really matter? So when we put this in a statistical model, we found that mothers who received guidance, regardless of their race and ethnicity from primary care providers, were 2 times more likely to be correctly using a child restraint system. So not only were they twice as likely to have a child restraint system in their vehicle, those that had received this primary care guidance were also more likely to have no errors in their use. And that was accounting for whether or not they had gone to a fitting station as well. So this guidance seems to be particularly important in improving correct rates of child restraint system use. Like I said, this was preliminary data, so we are expanding this now at the Children's Hospital of Philadelphia, but we're also looking at disparities that may arise across the injury timeline. So you can see there are several time points that we could implement an intervention to either prevent a crash or prevent injuries, to mitigate the severity of an injury given a crash, and then to also treat them. Particularly something that we're focusing on is looking at the treatment phase. So there's preliminary evidence to suggest that if a Black child and a white child are injured at the same level of severity and in the same way, the Black child is almost 2 times more likely to suffer long-term disabilities as a consequence of that injury than the white child. And it's not exactly clear what factors are playing into that. However, we are exploring different things like insurance types, access to long-term rehabilitation, and what type of hospital they were taken to after the crash. So if it had a level 1 trauma center or not. So in summary, in the first study, we used a meta-analysis to find out if caregivers, or if interventions targeting caregivers increase rates of child restraint system use, which we did find. However, we found that the majority of studies that we included in our analysis could have been implemented more rigorously or evaluated more rigorously. And by improving that methodology that the interventions are using, we would be able to have better information to provide future efforts with, or inform future efforts. In study 2, we found that younger children may be physically compatible with booster seats, but may also not be ready to use them as they're intended to be used, which could downplay the seat's effectiveness. We also, again, want to stress the importance of individual differences across all ages. And in the last study, we found that primary care physicians' guidance can increase the number of children seated in restraints and the number of people using restraints correctly. However, most minority families may not receive this information. So anecdotally, when we talked to our a few primary care providers that were helping us with this study, one thing that they brought up was quite often in lower socioeconomic status families, there are more issues that come up at these annual child visits. So things that are anticipatory like this kind of get pushed down because there's only so much time in the visit. And when there's, nutrition concerns and other things like that, those things really get targeted more, which may explain some of this. However, again, that was anecdotal evidence that we have not fully explored yet.
Thank you so much. We do have 2 questions specific to the data, and I think it actually addresses the 2 of your studies. The first question says, can you restate the disparity percentage for Black children less likely to be restrained? Was it 85% or was it 95%?
Yes, so that study is I know the first author's last name is Lee, L-I, and it was published in 2018. And I believe it found that 85% of children 1 to 3 years old who were restrained compared to more than, I believe it's 97% of all other racial groups. So more than 97% of Hispanic children were restrained and white children were restrained. So that's the disparity there.
We also have a question. Do you think that writing in a unique environment, i.e. the simulator, had an effect on the child's sitting position, especially with younger children?
Yes, so like I said, I know I went through that study very quickly. We did have a warm-up period where we did not include that in the analysis because we knew that children would find it fun and interesting and want to look at everything. So the first 5 minutes or so of the drive, we set aside just for children to kind of have that novelty wear off a little bit more so that they could then sit appropriately or not. So that's definitely a consideration and a limitation of the study. And that study does need to be replicated in a child's natural environment, so in their personal vehicles, using naturalistic methods. But we did try to account for that as much as we could.
All right, we're going to take this now to our second part of the presentation, which will be our panel discussion. So we'll switch over briefly to my screen. This is Suzanne speaking. Okay, so as I said, we have several panelists, and the first will be Dr. Rebecca Rabin. While she's talking, I'm just going to have this slide up about resources that are available on child passenger safety. Hopefully all of you know these resources, but for those of us from Maryland, I've listed the Maryland resources. So Dr. Rabin, can you hear us and can you speak?
I can definitely hear you. Can you hear me?
Yes.
Awesome. Good, because I was a little worried. So thank you, Dr. Sartin. I think that it's a very sort of well argued, point in terms of how you took the studies, sort of step by step, drilling down to the issues. I think one of the most significant points that you make, and I'm really excited about this sort of part of your data was the statement that that families are twice as likely to be correctly using their CRS if a provider has counseled them about that. And I think that that's something that if after you go over your preliminary data and it's final, that's something that definitely needs to be published or promoted to the American Academy of Pediatrics and disseminated widely, because I think that's very powerful in terms of getting pediatricians and others to understand the value of having that conversation with their families. So personally, I have been sort of interested and involved in injury prevention for a long time. I went to medical school at Penn, and so I was at CHOP as a medical student, and learned how to fit kids for bicycle helmets, and was part of a bicycle helmet rodeo, and to distribute them to the community. And then as I became an outpatient pediatrician, was seeing lots and lots and lots of misuse. And sort of as I explained to the residents that I teach now, and even parents, I have, you know, I will give kids immunizations, and I can talk to parents till I'm blue in the face about what they should be giving their child to drink and not having juice and things like that, and brushing their teeth and reading to their kids. But despite all of that advice, if I send them out of my office with a grossly misused car seat and they're in a crash, I haven't done my job. And I've had a patient leave after trying to after assisting her with improving the harness fit of her child's infancy. Come back a couple of days later as a visit for cold symptoms, come back a couple of days later to the office to have this child checked, because when they left the office, they were in a crash. And I encountered her at the check-in desk and was worried that the cold symptoms had worsened. And she said, no, she's fine in terms of that, but we were in a crash, and thank goodness, you had I really appreciated that you had gone over that with me, because I feel like she was safer for that. So so that's kind of my perspective and why I advocate and why I became an official CPST, so that I could speak from a place of knowledge. I have spent my entire career so far working in practices with majority Medicaid medical assistance families, and my current practice is majority Black families, although my previous practice was more of a mix, but still medical assistance. And I think that some of the issues inherent in CRS use with these families has a lot to do with their use of public transportation and Ubers and getting rides from other people. I think that's one important area that I'd be interested to hear, Dr. Sartin comment on, as far as what your research has been in terms of that, in terms of a reason for misuse when you have to lug a harnessed seat and uninstall it when you take an Uber or a Lyft to an appointment or to an errand. It certainly significantly diminishes your motivation to use them. Also, certainly families with multiple children without enough seats in the car to accommodate restraints. And and then also the use of hand-me-down seats and the sort of poor access to high quality, easy to use CRSs to low-income families. And then the last thing I guess that I'll say is, you know, I think I work really hard to also educate our residents. We have a small training program at Sinai, and I think that it's, you know, one of the things that I've found is that if you don't have your own kids and you haven't paid attention yourself, it's really hard to know where even to begin. And certainly I've educated my colleagues as well, whose kids have grown up long ago and haven't really been using car seats lately, to feel more confident in even giving some basic advice. So those are my thoughts. I don't know if, Suzanne, if, you know, I could go on and on about this, but those are sort of the highlights of the things that I thought of and I wanted to share.
Thank you, Dr. Raven. We'll move on to our next panelist and then have a chance for question and answers with all of the panelists, or Dr. Wood.
I'll be here. Yep.
Okay, so I am going to switch the screen over to Beatrice Brathwaite, and she will share her presentation and tell about her thoughts with this.
Beatrice Brathwaite. I am the Senior Injury Prevention Coordinator at the Johns Hopkins Children's Center, and we are one of the level 1 trauma centers for our region. So the CPS program that we have here at the Children's Center is comprised of 2 different components. It involves a special needs loaner program as well as a conventional car seat program. So our special needs loaners are specifically, or more so, for those femur fracture patients, hip dysplasia babies, and we have an array of vests, car beds, and spica-specific seats for them. We allow our Hopkins patients the opportunity to use these devices for up to 16 weeks at no cost, and then we kindly hound them to bring them back so we can use them for our next patient. And then there's also our hospital donated car seat program, which involves conventional car seats for Hopkins families in need. Typically, these are low-income families or families that have just been involved in motor vehicle collisions and need a safe device for their children to get home in. So within our hospital, we have a few CPSTs that are specifically for our Children's Center. We're divided between our injury prevention program, our pediatric rehabilitation program, and the pediatric emergency department. So based on our current policy, our PEDS rehab techs, there's 4 of them currently who are certified. They are responsible for taking care of our non-trauma patients, any rehab outpatients, as well as any NICU patients that have been within the department for 7 days or greater. People like me, who are injury prevention technicians, we handle all of the trauma and burn inpatients, as well as OBGYN or newborn nursery patients. OB outpatients, so our mom that has not yet delivered but knows that she does not have the resources quite yet to provide a seat. And we also see NICU patients that their stay has been less than 7 days. The NICU is the only unit in the hospital that specifically has hard, restrictions on who gets a car seat teaching and who doesn't. In the units, it's by request. In the other units, it's by request, but in the NICU, everyone is at least offered that prior to discharge. And then we have unit-based technicians such as the emergency room, and they can take care of the patients that may need a new car seat or need a spica seat based on their training during their shift. And we currently have 1, so we're hoping to get some more. And just a program that we are part of that really speaks to the disparity is Buckle Up for Life. It's a program created by Toyota and Cincinnati Children's Hospital, and it funds partnerships in at-risk populations with a special emphasis on Hispanic and African American communities. This grant, we were given the gift of safety partnership twice in my 5-year tenure here. So we try to hold 2 to 3 car seat events each year to help distribute the seats to community members that are not Hopkins affiliated. A stipulation of receiving the grant is that these seats must be given out free of charge. So you cannot charge a nominal fee or any type of fee for these seats. In 2017, we received 100 convertible and booster seats, and in 2019, we received about 75 convertibles and booster seats. We do not get any infant seats. But this is a program that we utilize strongly, especially for the African American and Hispanic populations that may come to the hospital who may need that next transition step for their children. And we are able to provide this resources as long as grant funds are available. And that is all that I have today. This is just some of my contact information in case anyone has any questions or comments later on.
Thank you, Beatrice. If you wouldn't mind switching over the presenter role to Nancy Boyd.
Good morning. For the past 3 years, I've worked for an organization called the Asian American Center of Frederick. That is kind of a misnomer as far as the name. Our founding director is Chinese, and so that's what she has named the organization. However, the section of Frederick that our office is located in is 58% Latino, and our office serves all communities, all nationalities, and especially immigrants, to help them to learn how to integrate into the community. So as I said, the area of the city that our office is located in is 58% Latino, 88% minority. My role there has been to develop community health workers, which if you're not familiar with that term, they're trained individuals, but they come from different nationalities, speak different languages, and considered trusted members of their own community. And then they can help to navigate community resources for the individuals in their community. But some of the things that we're seeing with different cultural individuals is that they may not have had child passenger safety regulations in the country that they came from. And especially with the Latino population, we see that many of them have a very low literacy in their native language, let alone English. So that makes them much more hesitant to get involved in English-speaking individuals, and they may not integrate into that English-speaking community well. Also, many of them are undocumented, so they don't trust authorities because of their immigration status. And they're unfamiliar with local resources, and they don't have support or access to online learning. Most of them do have phones, but they don't typically have computers or laptops or iPads. And even if they do, they may lack access to high-speed internet. But I think that as a CPST instructor, I've always discussed in the classes behavioral aspects of children, looking at that rather than the the minimum weight of 30 pounds on a particular child restraint. And especially with individuals in the class who have not had children or not have any contact with children, that's not always an easy discussion, but it is very important to talk to them about that. And I agree with what Emma said about the language barriers in primary care offices, that they may have to discuss medical issues, so injury prevention is not going to be on the forefront of their discussion with the clients. The other point that I wanted to make about that is that often the children will outgrow a harnessed seat height-wise before weight-wise, and that's may then cause them to go into a booster seat prematurely. But working with other populations, this is what we've found works the best. Steps to getting acceptance in that community is to listen first. Most of the immigrants that I've worked with over the past 3 years are very loving parents. They love their children. They want the best for their children. So we don't need to be judgmental and think that they're not taking proper care of their children. They just don't know what the best way to do that is. So if you listen first and honor their experiences, their history, and what little knowledge they may have, then you can start supporting them as parents and helping them to work with their children and teach their children and learn themselves. And we need to be both learners and teachers when we're working with them and investing in the parents and helping them to lead the way. That's all I have. So thank you.
Thank you, Nancy. So I think that our three panelists brought up some very good points and strategies for approaching some of these issues. So thank you very much for participating in this webinar, and stay safe.